Good evening, everyone. It is wonderful to see that our numbers are picking up and that we will have a good attendance tonight. I'm Anton van Schalkwijk, and I'm the head of coding unit at the South African Medical Association. And we will be looking tonight at specifically the big question about how do we code ethically and thereby getting our revenues up at the same time. So I trust that we can all see the shared screen. The webinar is proudly sponsored by Nelson Mandela's Children's Hospital and Partner for Life. Is that the screen that we all are seeing? Diane?
We can see you.
Yes.
Okay, fantastic. Thank you. I just wanted to confirm. All right. So in terms of our sponsors for tonight, the Nelson Mandela Children's Fund or Children's Hospital asked that we must please just mention that they are a specialist pediatric hospital in Johannesburg, providing services both to private and public patients. And then Partner for Life provides management and administration services to over 500 medical practitioners across South Africa. And if you are in need of practice management and administration service, then you can go to their website and you can find out more. Now, and a very special thank you to all of them for helping us to bring this to you. Now, our topic for tonight is that of ethical coding. Ethical coding can be summarized as coding the exact diagnosis and for the exact services that were rendered within the bounds of coding and ethical rules, guiding the medical profession. Now, this is very important because we have two things here. We have coding rules and we have ethical rules as established by the HPCSA, and all our practitioners are bound by those rules. Now, why is it important? First of all, there's a trust relationship between the doctor and his or her patient. And therefore, the patient trusts you as the service provider to code fairly. That's the first thing, is you have a trust relationship with your patient, and that is a very sacred trust. The second important reason is the ethical guidelines of the HPCSA. Third, the deterrence of forensic investigations by the medical schemes, and we will touch regularly upon that during this webinar. And then, of course, ethical coding is especially important, taking into account the economic realities of South Africa and its population. And when we talk ethics, when we talk coding, it goes to the heart of that economic reality. So, taking all of that into account, let's dive into our subject. And first of all, we go to the rules that impact on our coding from the HPCSA's side. Now, the first rule that we are going to have a look at is that it says in its rules that healthcare practitioners should make sure that their personal beliefs do not prejudice their patients' healthcare. Beliefs that might prejudice care relate to patients' race, culture, ethnicity, social status, lifestyle, perceived economic worth, That's a very important one for our subject tonight. And then, of course, age, gender, etc., etc., etc. It also says that the Health Professionals Council has determined for services not rendered, healthcare practitioners shall not charge or receive fees for services not personally rendered by either a healthcare professional, him or herself, or an unregistered person in his or her employ. Again, this is incredibly important because it speaks to services that was rendered and that must be coded in the end. The Healthcare Professionals Council has determined for services not personally rendered, healthcare practitioners shall not charge or receive fees for services not personally rendered by either a healthcare professional himself or herself or by an unregistered person in his or her employ. And then it also speaks to over-servicing. It means that the supply, provision, administration, use, or prescription of any treatment or care, including diagnosis and other testing, medicines and medical devices, which is medically and clinically not indicated, unnecessary, or inappropriate under the circumstances, or which is not in accordance with the recognized treatment protocols and procedures without due regard to both the financial and health interests of the patient. Again, this speaks also to coding matters because it speaks to both financial and health interests of the patient. And there is therefore some kind of a moral clause also built into this. The HPCSA also speaks to improper financial gain or other valuable consideration, means, money, or any other form of compensation, payment, reward, or benefit which is not legally due or which is given on the understanding, whether express or implied or tacit, that the recipient will engage or refrain from engaging in certain behavior in a manner that is either illegal and or contrary to ethical and professional rules. Now, again, this speaks to coding because what happens within the coding environment must be seen as legal and it must be seen as ethical and within the professional rules. So let's see. The second issue has to do with the structure of your accounts. Taking all of those information gathered now from the HPCSA, how does this speak to the structure of your accounts? And here we speak about split billing versus balanced billing. Now, balanced billing would entail that the patient and the medical scheme would both get the same account, indicating the portion owed or paid by the scheme and the patient. Split billing would be when the patient receives one account and the medical scheme a totally independent account. And where one does not indicate the portion owed or paid by the other. Now, let me put this bluntly, this is illegal. And this measure was implemented in order to prevent fraud and abuse of codes, to enhance transparency in coding practices is key here in order to ensure honesty. And this is both to protect you from the powers that be at the HPCSA, as well as from losses that could be incurred from staff. I can give you countless tales of doctors that have been defrauded by staff at their rooms because of split billing and because of the fact that two separate books are being kept. And in the end, the losses are great and cannot be paid back. So this is to protect you as a healthcare professional as well, in order to ensure transparency. Now let's look at the structure of your coding. And the first in line here is know your modifiers. Now, I'm only going to touch on this because this is only illustrative, but it is important that you as a healthcare professional knows exactly what the modifiers are and how to employ them. And one of the reasons is that it can really, really impact on your income if you do not use it properly. So one of these is modifier 0005, and we all know that if you have a surgical procedure, the most expensive procedure is paid or coded at 100%, then 75%, then 50%, and from there on 25%. Now, if it is listed in the wrong order, the scheme may not pay the account correctly, and the patient may not be held responsible because of it. Now, in the years that I have been working at the medical scheme, one of the things that we picked up very regularly is that the patient would phone in and ask, why wasn't this paid correctly? And I have received an account from the doctor now to pay the balance. And then we would see, no. This claim wasn't submitted correctly. The modifiers weren't applied correctly. The scheme has applied it correctly. And therefore there is a short payment because they don't care about what the amount is of which every code is being claimed. They care about the correct order of codes. And therefore, if a patient phones back and says, you must have a look at the coding, just check whether 0005 was employed correctly in the coding in order to make it valid. Another example is the modifier 0008 versus 0009. Now, 0009 is the one for a GP assistant and 0008 for a specialist assistant. And modifier 0008 may only be coded if there was a clinical medical necessity, not a matter of convenience. So say, for example, at the last minute, you have a problem obtaining a GP assistant, and you quickly phone a specialist friend in order to come and assist you. 0009 must be coded. And one of the issues that we have here is that if the schemes pick up that 0008 is being used a lot, what will happen with the specialist assistants is they will start their investigations, and they will have a look at your ICD-10 codes. They will have a look at the procedure, and if it is, for example, just a random procedure where you had skin excisions, but you have another specialist present, another general surgeon or whatever, then and it wasn't a specialized procedure where you really needed the hands and the eyes of an extra specialist, then you should code for a GP assistant. 0009. And on that, the MDCM is very, very clear. There must be a necessity for the use of a specialist assistant. So know your modifiers. If there are modifiers that are society-driven and that speak to a very specific society, know how to employ them, because the correct use of modifiers cannot only have a direct impact on the reduction of codes and their units, but also an increase and the correct payment of your claims. So know your modifiers. Know how to code for extra complicated work. That's the other one. What often happens, and we get a lot of these phone calls and emails where doctors ask in the inquiry, how do I code for this very specialized procedure that is very, very long, and it is very complicated? How do I code for that extra complication? And then the answer is always, do not upcode. You cannot code an extra code that's not supposed to be there, or unbundle because you think that you should receive that extra payment. It would be better to then use Rule J, which speaks to extra complexity and time. Now, extra remuneration from the scheme side is usually based, amongst others, on theatre time, as opposed to the time that would have been spent under ordinary circumstances, on average, on that particular procedure. So therefore, do not upcode. They will not pay for it. Do not unbundle. They will not pay for that either. It's better to negotiate Rule J according to extra time and complexity. An example is, for example, that a doctor is performing an intra-abdominal procedure, a complicated, time-consuming adhesiolysis needed to be performed. When performing an abdominal procedure, the lavage, anylysis, hernia repair is included into that procedure. So the patient's medical scheme will not accept any code related to the lysis and the hernia repair, etc. What they will do rather is they will rather see if they can grant Rule J instead of that, so the doctor can get fair compensation. The structure of your coding also must include correct ICD-10 coding. Now, this one is a bit of a conundrum because we often see that ICD-10 coding isn't being seen as very important. The practices would rather focus on the correct procedure codes, and they would neglect this part of their coding in total. And this is where you're wrong, because your ICD-10 codes tell the story of the condition. It tells the story of what you are treating your patient for. And if your ICD-10 coding is not complete, then you will most certainly see problems with your claims sometime or another. For example, when it comes to PMB, if you do not have the list of PMB-linked ICD-10 codes, it is available from the CMS. But use it correctly. Our people, when I talk about our people, I mean your patients often are PMB obsessed because they hear about it in the press, but they do not know what it is really all about. And there is often a huge pressure on doctors to amend ICD-10 codes in order to get procedures or other services paid as PMB. It is the doctor's ethical duty to code honestly and completely when it comes to ICD-10 coding. It is really not worth it to bow to that kind of pressure. It would rather be better to see how you can get to an agreement with your patient in terms of the costs. And here is very good advice, because in the end, this also has a knack of ending up in forensic investigations. If there is an unusual amount of PMB coding going on at your practice as compared to your peers in your society, and they will most definitely have a look about that and call you out on that. Now, in terms of your ICD-10 coding, there is also something to say about complicated follow-ups. Now, we all know Rule G. Rule G says that we have a post-surgical global period, and that global period of a maximum of 30 days must be adhered to for uncomplicated visits. Now, here is a way that you can always see to it that you maximize your coding and the units that you claim from the scheme. Because if it is a complicated follow-up visit, therefore not a routine follow-up visit within that global period, it is important to remember to code the complication through ICD-10. That is the only way that you have defense for that complicated visit that you have with a patient. Rule G does not apply to complication. So my advice would be to code for the complication first that you are seeing the patient for, whether it would be infection, whether it would be all kinds of comorbidities that is life-threatening to the patient. Code that first. Then code for, if you want to still code the illness, code that last. Because, the illness that was involved in the procedure. Because these are the ways in which you can, in a very effective and honest way, code specifically for complication when you see a patient, and that complication may then be coded for extra visits. Then, of course, tread lightly when it comes to emergency coding. And I have put this in because of all the issues that we see in forensic investigations. That is the thing that I always come back to. Please see to it that if it is an emergency procedure, that it is a bona fide emergency procedure. And your ICD-10 coding should be able to reflect that. A bona fide emergency, a medical emergency, is any condition where death or irreparable harm to the patient will result if there are undue delays in receiving appropriate medical treatment. So we use 0011 not because of inconvenience, but because of a genuine emergency procedure. Then when it comes to emergency visits, we might code. SAMA's position has always been, if it is a perceived emergency, then you might code for an emergency visit. Now, this is very important because one of the culprits that we often see is 0147, when it is an unscheduled or emergency visit away from the office, or away from the rooms. Now, when we look at it being unscheduled, then we must be certain that there was a certain haste in it. If there is not a certain haste in seeing the patient, and you have slotted that patient in for a round later in the day, then it sometimes must become a scheduled visit. And what I can tell you is that in the years that I've been involved in looking at forensic investigations and the coding data sets, we often see that they focus on the abuse of 0147. Because one of the things that we must realize is that the majority of the medical schemes still cling to 0147 as portrayed in the 2006 version. And there it only says that it is an emergency visit, not unscheduled as well. So my advice would be, especially when it comes to 0147, tread lightly with that one. Do not abuse it. If in doubt, rather use 0145. And again, your ICD-10 coding is incredibly important, because your ICD-10 coding will show the reason why there was a haste, why it is unscheduled, why it is maybe an emergency. If it is a perceived emergency, a perceived heart attack, although it was not, it must be coded in terms of the symptoms, so that the scheme may see this person had serious chest pains, this patient was short of breath, and because of that, the patient needed to be seen very urgently because it could have been a heart attack. That's only one of a series of reasons why it may be perceived as an emergency. But it is important that we use it wisely. Further, be aware of the coding guidelines of your discipline society. Your society each decide what correct coding should be. And most of them have comprehensive coding guides. If they don't have it, then it's time for that society to overhaul their coding guidelines, because it is here in terms of ambiguity where we see that that doctors pick up problems with the medical schemes and forensic investigations, because a lot of the time they don't know how to code properly according to the guidelines of their own profession. In general, recent codes are being cross-referenced with CPT coding by a lot of these societies, and then CPT coding rules apply. So when it comes to newer codes, the schemes are going to have a look at those codes and they're going to apply those rules. Greater clarity is always to be obtained from your relevant society. And if in doubt, SAMA's coding policy is to check with the relevant society in their guidelines. If we are in doubt, we take a beeline to the society and ask help. We don't know how to solve this problem. One of the issues that must be attended to, again, if you are part of the structures of a coding society or of a specialist society, and the society has not updated their coding rules for a very long time, and you have the ability to assert influence, see to it that those rules are not only being updated, but shared with relevant groups such as SAMA, such as SAPPF, for the simple reason that we are being asked by schemes, what is the correct coding for a specific procedure. And then we must be able to rely on that society and their coding rules. And if you do not have a dedicated coding person in your ranks that can assist with that, then it's time to fish for one, so that we can push on your button when it's needed. Now, in terms of that, we also must have a look at record keeping. And again, I'm coming back to forensic investigations, because forensic investigations are the big problem, or big problems means big problems for a lot of practitioners. Now, your records must include your visitor logs, correct NAPI codes, clinical notes. These are the only lasting witnesses to the work you have done. Now, we all know that when it comes to record keeping, this is the bane of the existence of nearly every practitioner out there. But they will be your ultimate defense when accused. A lot of the problems that we see when it comes to forensic investigations has to do with this, where records are either not being kept securely. We've had a situation where records have gone lost. We have had situations where visit records and the 0190 claims do not correspond. And that medical scheme will send an investigator. They will go and sit in your office, and they will pour through all your records in order to see if you were honest in terms of your visits. In terms of your procedures, complete notes must be kept with accurate ICD-10 codes. If the procedure is not mentioned in your ICD-10 coding, it may not be coded. If your notes do not mention it, it may not be coded. And this is one of the problems that we sit with in terms of claims not being paid. Then doctor says, what about this code? And then we ask, please show us your note keeping on this. And then we can see, but doctor did not mention this particular procedure. And therefore, when it's not mentioned, it may not be coded, and the schemes have a right to say, we will not pay for it. If there is no record in your visitor logs, the visit may not be coded. And therefore, it's important to cross-check those regularly in order to see to it that the record of your coding and the record of your visits correspond. Choose a secure site to store old records. Here is a very, very good piece of advice. Choose a secure choice. Just because your friend has a garage or is renting a place and there's some extra space, and you don't want to waste money on secure storage facilities, don't fall for that. We have had a doctor, one specific doctor, that has lost most of his old records, and the schemes picked up on it, and it nearly ruined him because he couldn't show a singular file older than 3 years. So just take note of this. Okay, then in terms of your coding, we must also have a look at how to approach no-shows. Now, a no-show is that patient that just doesn't pitch up. In terms of the HPCSA, they for a very long time were hesitant about it, and then eventually they came through with very strict guidelines in terms of no-shows and how to code for Rule D. Now, Rule D says that the cancellation of appointments and no-shows in cases where a patient did not show up for an appointment or did not take timely steps to cancel an appointment. Rule D may be applied to the relevant consultation. So you can code the consultation and you must show on your account that it is a Rule D account. The reason for that is that the medical scheme should not be held liable for that. So if you submit that particular claim, or if the patient submit that particular claim, they will not pay for it. Now, if you are not certain on what these guidelines are, you are most welcome to contact us, and we will forward those guidelines to you. It's very important that you keep strictly to it, because the HPCSA is not going to accept anything less than what they have ruled on, and we have updated the MDCM book accordingly. One of the reasons for that being that they have basically copied and pasted the Consumer Protection Act on no-shows and cancelled appointments. And they have made it applicable just as it is on the medical profession. So whether we like it or not, what is standing on in what is being written in the MDCM in our editions of the past few years, I think it was since 2020, 2019, if I'm not mistaken. What we have written in that regard is basically right out of the ruling of the HPCSA. Then the use of correct NAPI codes. Another thing that is really, really being a problem when it comes to forensic investigations is when GPs dispense and they do not adhere to the correct NAPI codes when they code for the products that they dispense. Now, in terms of that, I have seen huge clawbacks from medical schemes simply because it was not the correct NAPI codes that were used for a specific generic medication, especially. And you may not use the patented medications NAPI code in order to claim for the correct generic. So keep that in mind. If you are in doubt, it is always good to check with people like MediCredit who advise the medical schemes on the correct NAPI codes, so that you are in line with what you have dispensed when you code for it. It is also important to stay firm on your principles. There's huge pressures in these days of patients that will sometimes request services for family members or friends, and that it then be charged from their own medical scheme. Some also attempt to get a sick note from a doctor, and he will then claim from the fund, although the patient is not really sick. Please beware that of the fact that forensic audits often also involve sting operations. We have seen it in practice, where a particular scheme will send in an undercover operative. That person will tearfully beg the doctor for a favor in this regard. And if the doctor buckles, that doctor is in deep, deep trouble, not only with the scheme, but they take it directly to the HPCSA because this doctor has fraudulently claimed from them. And I have even seen that doctors have been charged at SAPS level, South African Police Services level, because of this kind of tactic. So stay honest, although you are a compassionate human being, as you should be, because this is the profession that you chose. It is important that you stay honest and rather see if you can help the patient than fall for this particular scam. Schemes share results of forensic investigations with each other, and this is a very important thing that you must note. If you have been caught out that you abuse certain codes, if you have been caught out that you have poor record keeping and you cannot prove all your services, if you have been caught out in terms of the kind of scam that I've mentioned, the schemes will not only share this information with the authorities, but they will also share it with each other. It is not worth the risk. It is not worth the risk. Protect your patients and protect your practice with good coding practices, with solid coding practices that can be proven and that is being done honestly in order to stay on the safe side. I'm hammering on this because forensic investigations is a huge problem, and often the mistake is not that the doctor is dishonest. Most often the mistake happens because the doctor is not aware that he is making a mistake or she is making a mistake. And then we see tearful practitioners who must often cough up hundreds of thousands of rands because of it. So if you are in doubt, get into contact with us, get into contact with your society or whichever association you belong to, and be certain that you get into contact with coding experts that can assist you if you are not certain. Then final tips. I'm going to share a very specific situation with you that I have personal knowledge of, and that speaks to correct coding and how it impacted on that particular practice's claim that was received by the medical scheme. This particular patient was taken into the emergency ward with serious post-procedural, post-operative pain. And the patient was treated at the emergency ward. But when the patient was not admitted, the patient was sent home after that, say after an hour and a half, the patient was sent home. The practice went and used a routine ZICD-10 code, which basically tells us only that the patient was seen. Together with that, the practice also used an ICU code, one of the ICU codes, with no solid evidence for the patient either being treated as an ICU case through the way that the patient was managed or through the way that the patient's condition was coded. And well, the medical scheme rightly said no, that they are not going to pay for this. They denied that claim. What should have happened is that the practice at the emergency ward should have used the correct 7.0 code for that particular particular medical scheme, because that particular medical scheme uses the emergency ward codes that's contained in the MDCM, And they should have coded the correct symptoms that the patient was admitted into the emergency ward with, without hospital admission. That claim wasn't paid, and what happened is the patient ended up with that particular account, and the practice wanted to get the money out of the patient then. But the fault was with that particular practice. And if they coded correctly, which subsequently happened, the claim was paid without any problems. So it is important also not only to know the proper ICD-10 coding, correct ICD-10 coding, knowing whether it is PMB or not, knowing what codes a scheme would accept or what not. But in terms of the description that you give there, you must give the complete story. I've been in a meeting earlier this day, or earlier today, where statistics in terms of ICD-10 coding revealed, amongst others, that some practices would go and code for smallpox. Now, we know that smallpox have been eradicated from South Africa decades ago. Most probably it is because somebody at that particular practice basically does the coding. Doctor doesn't involve him or herself with the coding. And therefore, an error is being given through in terms of what was the matter with the patient, what was the correct illness. Now, here we have a lot of problems that transpires, because it could, somebody can take it seriously, and it could cause a cascading effect in terms of the National Department of Health, because it is not even it's not only a communicable disease, but it is also a disease that must be flagged by national government. So it skews our national statistics. All of those codes that are being claimed are being gathered. It is being analyzed by the Department of Health, and it is also being sent through to the WHO, the World Health Organization. And it is therefore important that you as a clinician, and even you as a person that works at the Bureau, be certain that the coding for that particular illness is correct, in order not only to get your claim paid, but also to have accurate record keeping levels on national government side. They track diseases, they track the significance of its occurrence throughout the country, and we need to give through accurate information. Now, a few final tips before we go to the Q&A session. In terms of your contract that you have with your patient, your moral obligation, in terms of your obligation to the larger community, here are a few tips. Be clear from the start that your rights are visible, that the patient is under no illusion about subsequent short paid bills after the scheme has fulfilled their part. Be clear from the start. It is important that the patient knows, if you do not claim for medical scheme tariffs, nobody can force you to claim medical scheme tariffs. SAMA cannot force you. But if you do not claim medical scheme tariffs, make your patient aware of it from the start. For scheduled procedures, provide a quote and advise the patient to check with their medical scheme regarding their payments. Now, here there is an HPCSA rule that speaks to this, and that is in terms of informed consent. Everyone has the right to be given full and accurate information about the nature of one's illness, diagnostic procedures, the proposed treatment, and the risks associated therewith, and the costs involved. Now, this is incredibly important. There's no worse thing after you have been through a surgery that you get that statement in the mail and you did not even expect that you were going to have co-payments. So it is strongly advisable in terms of ethical coding and in terms of the ethical use of your rand conversion factor that you choose for your practice, that you make your patients aware that there may be a co-payment. Simply for the sake of covering yourself on that, because if there's no informed consent, the patient goes and take it up with the HPCSA. It may land you in the hot water. So let's keep that in mind when we encounter our patients right from the start. Okay, that is as far as this particular lecture goes. So we will be going over to the questions and answering session. Solly Lyson, it says, why do we need to code diagnosis to stage 5? Well, I can tell you that one of the reasons why we have this particular why we have this particular discussion at the moment is I have been in meetings today where there is a very, very active attempt from government side, from the Department of Health side, in cooperation with FISC, the Private Healthcare Information Standards Committee, to update these matters and to get South African statistics straight. So I think the importance of this is get into the habit, because sometime or another we are going to see it. But it's also the honest thing to do in order to code accurately. Some of these ICD-10 codes may seem irrelevant, but it also serve as a motivation should you wish to code in terms of your procedural coding and in terms of the procedures that you do to code for that rule J that you want. So that's one of the things that we need to keep in mind. When patients see me for a PMB, diabetes, but often have another medical query. Sorry, this thing has now jumped. I attend to the other issue, but do not bill and rather script to save the patient's funds. Will medical aids pay for the secondary diagnosis if seen in the PMB diabetic consult? When patients see me for a PMB, but often have another medical query, I attend to the other issue. Yeah, I should say, you know, if the patient is also being seen for the PMB, you should code both. The reason for that being, okay, your consult will then be viewed as PMB and part of the basket of care. But again, it's very important that you code for all the illnesses that you see this patient for. One of the reasons why we say this is, should there be an investigation and you are being investigated for, say, you only coded for the PMB, but you dispensed or you prescribed medication that was not in line with that PMB condition, then that could be a problem for you, because then they might see it as over-servicing. So if you code it accurately, then it shows the complete picture of what transpired there. Where do we access the complete coding list? It would seem that the codes we generally used are the ones handed down by the seniors. Now, we have the Medical Doctors Coding Manual, which has the most updated codes out there. So you can go onto our website and you can order the book. SAMA members get discount. If it speaks to the ICD-10 codes, now it's important. This is an important one. South Africa is only going to be updated to the 2019 version of the World Health Organization's ICD-10 code list this year. We are working on it at FISC level at the moment. South Africa still sticks for the time being with the 2014 version. So if you go onto the internet and you Google it, one of the problems that you have is you will most probably end up with the clinical modified version that the Americans have. So if you get our EMDCM, Electronic Medical Doctors Coding Manual, and by the way, members get the first license for free. There is also an up-to-date master industry table list of proper ICD-10 codes to be used in South Africa. So if you obtain that electronic version, you basically have both full sets of codes that you may use. There is also an electronic browser for ICD-10 codes if that's the only thing that you desire to use, and that can also be downloaded from our website. The licensing fees for that particular piece of software annually is very, very low. How long must the records be kept for? Anesthesiology. Dr. November, I would, if I tell you now, I think I will be wrong, because there are HPCSA guidelines. I would advise you to email us, and we will make sure that we get the correct information to you, because that is very, very important. Is there not the ethical responsibility by the HPCSA or CMS to train staff on coding? No, they will not. They will not train you. The CMS is, and SAMA is, as a matter of fact, also at loggerheads with each other, because the CMS has sent out a circular at the end of last year where they said they affirmed the only valid code set that they accept is the 2006 version, and that when schemes accept newer changes in the coding set, they must make sure that it does not affect their funds or the patients adversely. So the CMS is not the correct people to ask about that. HPCSA is basically just a regulatory body. SAMA does provide some sort of coding and coding advice and coding training, and we endeavor, especially from next year, to see to it that we work in conjunction with specific doctors groups in order to to help facilitate the training of our doctors in the different societies. Please send me the guidelines and rules that are being referred to. We can do that. Dr. Mpande, please email us in this regard, and we will most definitely send that through to you. What recourse do doctors have when patients have purchased a medical aid and have absolutely zero knowledge of what they are paying for? Surely this blanket selling by some schemes, when patients genuinely do not know what is covered, should be reported and is therefore is there a number to report this to? Yeah, this is unethical, and it is often being worded in such a way that patients do not clearly understand. My recollection when I worked at the scheme was also that patients rarely read their brochures, and that they simply sign up for what they can afford. And I've often said to medical scheme members when they tackle us on that, when I had telephone conversations with them, I would say, this is our lowest option. But this can be equated maybe to a VW, but you want the services of a Mercedes-Benz S-Class to be paid. And you get what you pay for. So what I would really do is just refer the patient back to their medical scheme. They have a contractual obligation to their members in that regard to explain properly what is meant. But there's not really a recourse. You can go to the CMS, but as long as it is being said in a brochure, they are happy that it has been communicated. We decided what can be billed for and what can't, e.g. pap smears and ear syringing cannot be billed for as separate procedures. How can one change this ruling? Now, in terms of this, SAMA coding is in line with international coding standards. And in terms of international coding standards, and we are aligned in terms of CPT coding, that is being included. And what I have said to doctors when we have discussions about this is the drive from our side and the drive from SAPAF's side in order to get this to get past this is to fight for tiered consultations. Now, my advice on you would be, if you have to code for something else like that would be time consuming, rather than using 0190, use 0191, 0192. Use those two codes rather in terms of the time that you used. And yes, the scheme will be paying a flat fee. They will not remunerate you extra for that, but you will have a legal recourse in order to send the bill, the extra of the bill to the patient. That's the only recourse you have at the moment, because even if we change it, and this is where the problem comes in, even if we change it, the schemes will not necessarily accept it. That's the first thing. The second thing is, because this was included since before 2006, that the Council of Medical Schemes accept, what's going to happen is they are going to take it most probably up with the Competition Commission, because this has financial repercussions for them. So this is a bit more of a minefield than what most would like to know. With all these complexities with claiming, will it not be easier to stop direct payments to all doctors? Let the patient pay the doctor directly and let the patient be refunded by the scheme. Well, there is this option, and you can have this arrangement with your patients. But one of the things that I've picked up in terms of our committees and in terms of our engagements with doctors is that their problem is usually with the opposite. That schemes stop paying them directly, then the patient doesn't pay them. So you will have to have an arrangement that the patient must pay before the procedure, and then they can claim it, or shall I say, right after the procedure or whenever, and then they can claim it back from the medical scheme. It's a valid way of doing. If the schemes can stop direct payments to the doctors can stop it themselves as well. But you will lose patients in the meantime, that I can assure you. It's great to see that SAMA does talk on what doctors must not do. But has SAMA ever done talks to assist doctors to code correctly and appropriately, especially for procedures, etc., in GP rooms, so that doctors don't lose out financially whilst still billing within their ethical guidelines? But this is a very interesting thing that we can take up. And this is something that we can most probably have another webinar on, in what can you code for, and how to code correctly for it. So this is something that I will most definitely keep in mind for future engagements, because this is the first of many such engagements that I will have with the profession in the future. Dr. says he's an orthodontist and a prosthetist. I'm not sure if this is the correct question for this specific session, but I would like to know, if I claim a specific item for a medical aid and I get the response not paid, scheme exclusion, please use a different code. Is the medical aid not asking me directly to commit fraud, or trying to force me to use items that they approve instead of trusting my judgment to supply what I deem necessary? If I supply a device that is properly NAPI coded, how can the medical aid refuse payments? Now, this is a very interesting one from an orthotist and prosthetist. In terms of PMB, they might be wrong, especially if it's PMB. It might be wrong. I know of a very specific case of a friend of mine who was in a motor accident, and she had to undergo emergency back surgery. And when the medical scheme did not want to pay for the back brace, they said it's not included in PMB. She took them to the CMS, and the CMS ruled in her favor. So that's just one. That's just one of the things. I would say it's not only your NAPI code, so it's also your ICD-10 code that you must check. Is your code, your ICD-10 coding, aligned with PMB coding? Because once they see the PMB code or the PMB linked code, the story might be something else. So check your ICD-10 coding and confirm that your ICD-10 coding is in line. Otherwise, they have the right to impose certain limits and limitations on the use of devices. Unfortunately, the CMS does allow for it. In terms of the changing of your codes, that's a problematic one. If that's the prescribed code of your specific society, then it does seem that they are asking you to commit fraud. So just confirm that the code is correct. That's the first step that I would take. The second step that I would take is engage with them and demand to speak with a medical professional at the scheme, and not only with a call center agent. Because if it's the valid code, that code should be adhered to. And I would agree with you. It would amount to fraud if they ask you to use a code that's not applicable. The next question, I have a problem with medical aid dictating on ICD, despite you knowing exactly what the right diagnosis of the patient is. E.g. Z34.9, supervision of a normal pregnancy, unspecified, where Z34.0 would be primogravate. Yeah, that's something that's problematic. First of all, I would most certainly make certain that the ICD-10 code is applicable, and then stand on your principles. You see, the problem is that if you let them dictate your ICD-10 codes for you, and you know the ICD-10 code is correct, there's absolutely no excuse. It is skewing the statistics. If you are uncertain about the correct ICD-10 code, speak to your society, or speak to us, speak to SAPPF, and see if any of us can assist you. In the end, there is coding assistance out there if you need it. But if the coding is correct, it's always good to have some backing from us, for example, with a letter that says, well, we agree with this, doctor, and what are you going to do about it? And then, of course, the other thing is we must just make sure that you use an ICD-10 code that is in line with the 2014 version of ICD-10 and not a later one. I have one from Natalie here. Please note, should always cost estimate, not a quote. Yeah, you're right. Sorry about that. Cost estimate. A quote is a final figure and cannot change. And things change in medicine. You're quite right, Natalie. I do agree with you on that. And send those cost estimates to your patients. They need to know more or less what the cost is going to be for them. What if one gets the prices from a third-party vendor software like MedPrax, for example, and one is then accused by the medical aid of overpricing? Ooh, that's a difficult one. I would like to know. I would like to know what prices are we talking about here. Is it NAPI code prices? You have to specify for us. So, Dr. Mulowitsi, I would really say, please send us an email. I will confirm our email address at the end. Please send us an email in this regard. Which body is responsible for determining tariffs? You determine your tariffs. The medical scheme determines their tariffs. SAMA is not responsible for tariffs. Let me put this as clearly as possible. We are not allowed to do it. So please be reminded, SAMA does not in any way tell you what you should price. There was a determination by the Competition Commission in this regard, and we had our prescribed prices up until that point. Because we moved, we only publish units. You determine your rand conversion factor. The schemes have taken a position in where they use the rand conversion factor each year from 2006, and they applied the average inflation rate to it, and then they decided on their rates for the next year. So each scheme is responsible for that, and they may not collaborate in that. How long a period of time do you advise us to keep? I think this is one that I have tried to answer this one. Doctor, please send us an email, and we will answer this one for you directly. We will forward you the HPCSA information directly so that you have it on record. In terms of the longevity of your patient records. Please clarify the situation regarding no shows. Again, I would advise, Doctor, please send us an email, and we will most definitely send you the information. If you have the MDCM, go and look under that rule. It is there. A doctor group is running the casualty at our local private hospital. A doctor is on call on the premises in the hospital. Charges are levied for a normal 0190 consult, as well as the emergency visit away from the doctor's rooms. Is this ethical or legal? Yeah, I would say this is one that we should answer via email. Please email us on that one. I think for the rest of it, I see Natalie has one here for Natalie. I think the number of years that we keep it is 21 years for young patients. I must just make certain of that. But yeah, it might be as long as 21 years that records are being kept. So if any of your, yes, for obstetrics, thank you, Natalie. I see that we are quite over our time. If any of your questions have not been answered, please feel free to email us. Our email address is coding@samedical.org. coding@samedical.org. We will answer each and every one of your coding questions. We are there for you. Please remember that none of those inquiries are being viewed as unnecessary. You ask us your coding questions, and we answer them. And if we don't have an answer, we will go to your society and see if we can figure it out with them. Thank you so much for joining us this evening. We are almost 20 minutes over time, but I think we had somewhat of a good time together. Have a great evening. Sleep well, and all the best for tomorrow. Tomorrow is Friday. Enjoy your evenings, everyone.